and we have now built up an experience of 25 cases. So I think maybe now I can share better with you our personal experience. First and foremost, it's a great honor because he's my dad's teacher and dad's a very good friend. So I think it's a great honor for me.
Meeting every week, more than 25.
Yeah, more than 25.
More than 25.
I'm aware of that.
If someone is late, Sunday pulls him up.
I think it's
I today
quite commendable.
message him and he starts the meeting.
It must be one of the rare forums which is continuing for such a long period.
And the backbone of the meeting is Dr. Kokane and Dr. Apte. They are our teachers. No?
Sunday and Pastor.
I am now working closely with Sir Kante. He's coming quite regularly to keep an eye on
Pastor is coming.
So he's going there now?
Yeah, so Baruwala sir and me are cases
You
together.
are our register.
Yes. So, thank you very much once again.
It's like a home field for you.
Yeah, it is at some level.
We enjoy talking to us.
Yeah. So, I'll talk to you today about Tavi or transcatheter aortic valve implantation. So, why the need for today's discussion? Because of two very simple points. We are living longer and we are living longer courtesy of more medical procedures in our lifetime. So this is a simple diagram which I have picked up from Google, and if we see the lifespan in 1960, the average lifespan was 45 years, and in 2020 the average lifespan in our country is 70 years. And especially in the urban areas, in the affluential communities, lifespan of 80-85 is not uncommon now. But this comes at a cost. The cost we are paying is that we are undergoing more medical procedures in our lifetime. So this is the US data which says that as of 2002, the average human being used to undergo 9 surgical procedures in his lifetime, out of which 3 are major procedures and the remaining are minor procedures. And this number has been increasing by about 5% every decade. So if we extrapolate it, then currently an average person will undergo about 11 surgical procedures in his lifetime. So
Per
this
person.
per person. So it may be an ordinary cataract, it may be a hip replacement, it may be prostate surgery, it may be nail removal, but the average is 9 to 11 per person in his lifetime. So when we grow older, we encounter more diseases, and as the lifespan has been increasing, we have encountered this new problem of aortic stenosis, which is because of the degenerative affection of the aortic valve. So in a paper which was published by SGPGI Lucknow in 2019, they have estimated the prevalence of aortic stenosis to be 46 per 1 lakh population, which means that every year 1.5 million patients are getting added in our country with aortic stenosis, and only about 30 to 40% of them are receiving treatment. 60% of them are either not diagnosed, and if they are diagnosed, then they are not getting treated. As of 2013, there were 10 million people above the age of 80 years in our country. And out of that, if we see the mortality of aortic stenosis, it has been steadily rising, and in 2017 it was almost 5,000 patients per year. As compared to that, if we estimate the number of TAVIs which are being done, it's still only 1600 TAVI per year. So there is a huge gap in the disease and the treatment which is being offered, and that is partly because of lack of awareness and partly because of the cost. In US and in North America and Europe, they do about 20,000 TAVIs per year, and if we estimate the need in India, it is 3 times that of both combined. So if they combine the volume in the US as well as North America and we add it up, our need is 3 times that. So that is the huge unmet need of this disease which is now coming into light. So I think most of you will be aware about aortic stenosis. I will divide my talk into three parts. Briefly, I will just touch upon aortic stenosis. I will discuss Tavi more in depth, and lastly, I will discuss our own personal experience. So aortic stenosis is the degeneration of the aortic valve, which results in obstruction of blood flow from the LV into the aorta during systole. There are three common etiologies of aortic stenosis. The first one is degenerative aortic stenosis, which is usually encountered in a tricuspid native valve, which occurs after the age of 70 years. Second is a bicuspid aortic valve, which degenerates earlier, roughly between 50 to 60 years of age. And lastly is a rheumatic heart disease, which is decreasing in prevalence but is still seen in some parts of the country. Rheumatic heart disease generally presents with a mixed valve disease. Isolated aortic stenosis is seen in only 8% of rheumatic heart disease. But we do see a lot of patients who have undergone mitral valve surgery for rheumatic heart disease in the past and who now come with aortic stenosis. Yes, sir, but penicillin is not readily available. So a lot of patients have discontinued penicillin prophylaxis now, because of physician anxiety and unavailability of the drug. So I have seen many patients who say that physicians have refused to administer penicillin in rural areas because of fear of anaphylaxis. And oral penicillin is not freely available. Pentids, which was is not freely available. There is a lot of interruption in the stock which happens. So that is one of the concerns. So all of us know that there are three cardinal features of aortic stenosis, which is angina, syncope and dyspnea. But the interesting thing is that when the patient has mild or moderate aortic stenosis, there is a long latent period of many years in which the disease progression continues but the patient is asymptomatic. And hence it is important for us to recognize patients in this time frame, because once symptoms develop, the prognosis worsens very rapidly. So symptoms develop very late in the disease, and the rule of 3-5-2, that is mortality is 50% 5 years after the onset of angina, 50% 3 years after the onset of syncope, and 50% 2 years after the onset of dyspnea. So if we have 100% of patients of aortic stenosis and they develop symptoms, at the end of 5 years, 50 will not be alive. So the prognosis of symptomatic aortic stenosis is worse than grade 4 cancer. It is 50% confirmed mortality at 2 years interval once they develop heart failure. Also, many patients who are asymptomatic can present for the first time with sudden cardiac death, and that may be the first symptom where they do not develop any symptom of aortic stenosis. So it is very easy to diagnose aortic stenosis. Actually, I am sure in your time aortic stenosis was not getting missed because everyone was auscultating the patients. But now aortic stenosis is very easily missed, and we commonly see patients who are treated for heart failure with LV dysfunction, and if you auscultate, there is a loud murmur, which is not picked because 3 doctors did not auscultate. So, clinic. Yes. They have even put the patient on Vimada and creatinine had gone up to 4. So, actually aortic stenosis should not be missed. If you just auscultate the patient, it will be very easy to pick it up. But there are certain cardinal features of aortic stenosis, like a slow, low volume pulse. I think all this is not necessary for you, but there is a low pulse pressure, there is a loud rasping murmur which is heard in the second intercostal space, which radiates to the carotids, and there is an ejection click in a bicuspid aortic valve. The X-ray will usually not show cardiomegaly, it will be a normal X-ray. There may be some poststenotic dilatation of the aortic root in rare cases. ECG is very characteristic. Once they develop LV hypertrophy, they will have LV pressure overload sort of pattern with tall R waves and sagging ST segments. But the cardinal feature of a murmur should prompt for a search for aortic stenosis. So the diagnosis of aortic stenosis is confirmed on echocardiography, wherein there are certain parameters which we need to look at. when we put a color Doppler across the aortic valve and the peak velocity is more than 4 meters per second, that confirms severe aortic stenosis. When the mean gradient across the aortic valve is more than 40, and the valve area, which is calculated by continuity equation, but it is available in most of the newer machines, is less than 1. All this holds true if the patient has normal LV function. Many times we see patients who have LV dysfunction and whose LV is very weak and it cannot generate the gradients because the force of contraction and the stroke volume is very low. And that entity is called as slow flow, low gradient aortic stenosis, in which because of LV dysfunction and reduced stroke volume, the aortic stenosis is masked.
Yeah, the same thing is no murmur aortic stenosis.
Correct, no murmur aortic. And we commonly see these patients. So in our lab, echo lab, we have now made a rule that every patient who has got LV dysfunction should be evaluated for aortic stenosis by assessing all the parameters. And if the indexed valve area is calculated to be less than 1, then that patient should undergo dobutamine echocardiography or a calcium score of the aortic valve. Then in that situation, we do pick up many patients who have clinically significant aortic stenosis, but they are missed because of the low EF. Other useful tests which can be done and which we are applying more commonly now is a dobutamine stress echocardiography, which is done by giving low dose dobutamine at 10 microgram per kg per minute and increasing the ejection fraction of the heart and then eliciting the gradients. If the patient has a low flow, low gradient AS, the gradients will go up after administering dobutamine. And in case if there is a doubt, we can perform like how we do a calcium score of the coronary arteries, we can do a calcium score of the aortic valve, and if the calcium score is more than 1200 in females and more than 1800 in males, then there is a high likelihood of having severe aortic stenosis.
Sir, would you like to say at this point a person having improved or increased gradient after dobutamine has better chance of going to a Tavi?
So the short contractile reserve is preserved, so we expect that after Tavi or surgery, they will have improvement in ejection fraction. That is preserved contractile fraction, and it correlates with a better survival in the short term. And we commonly see that the ejection fraction normalizes 2 to 3 days after surgery by just changing the aortic valve. So these are some important salient points of aortic stenosis. First, AS is a progressive disease. Anybody who has developed mild aortic stenosis will develop moderate aortic stenosis, will develop severe aortic stenosis unless something else kills him. It is a 100% progression from mild to severe AS. Only thing we don't know the speed of deterioration, although old textbook mentioned that velocity increases by 0.7 meters per second and valve area decreases by 0.3 centimeters square per year, but there is no real data to validate that. So newer textbooks, they have removed that rate of progression.
Can you reject this progress?
There have been multiple trials of statins, but they have all failed. There is no medical therapy to suggest we can delay the progress or regress aortic stenosis. They are trying now in the analysis of the PCSK9 inhibitors, although now there is a lot of controversy about that. In one subgroup, they found that there was some delay in progression, but there is no valid data right now. So
That means once stenosis,
it will always progress, and hence it is very important to monitor those patients at regular intervals. So mild aortic stenosis at 3 to 5 years, and once moderate, then every year or 6 months.
If it's once you have stenosis, you need something to be done in 5 years.
Usually, if we estimate that valve area decreases by 0.3 centimeter per year, then 5 years will amount to 1.5 or 2, probably 5 to 7 years, you will progress to severe aortic stenosis. The rate of progression is variable and difficult to predict, and there is a certain progression of mild or moderate AS to severe AS. Aortic sclerosis is different, sir. Aortic sclerosis does not definitely progress to mild, moderate or severe AS, but once you have a gradient, then it will definitely progress. The risk factors for aortic stenosis and coronary artery disease are the same. But whereas trials have found that we can retard the progression of coronary artery disease by statins, diabetic and blood pressure control, the same is not applicable for aortic stenosis. So coming to the crux of today's lecture, we have a time-tested treatment for aortic stenosis, which was surgical aortic valve replacement or SAVR, and we could either choose a mechanical prosthesis or a bioprosthesis. In 2002, Alan Crevier performed the first case of TAVR, which is transcatheter aortic valve replacement. But technically it's not a replacement, so now the term has been coined into Tavi, which is transcatheter aortic valve implantation, because we are not removing the old valve. So that was done in 2002 as a compassionate basis for a patient who was certain to die. The patient survived and ultimately died of lower limb complications. Since then there have been number of valves, a number of trials, initially starting with high-risk population which were unsuitable for surgery, then progressing to intermediate risk patients, and now we have good data on low-risk patients, and all of them have shown that TAVR is equivalent or non-inferior to surgery, and in certain respects it is found to be superior to surgery. The valve which is implanted in TAVR is always a bioprosthesis. So the first indication for a patient not to undergo TAVR will be if he needs a mechanical prosthesis. So anybody who is younger, say less than 50, then TAVR should not be offered because they should get a mechanical prosthesis. Between 50 and 65 is debatable, and after 65 we can offer both therapies. So coming to the indications and contraindications for TAVI, patients with severe aortic stenosis who are eligible for a bioprosthetic valve, who should have, as per the guidelines, age more than 65 years, but in a recent TCT data in the US, they found that between 60 and 65 years also 50% of patients are getting a TAVI.
60 years of a bioprosthetic valve, do you consider the life of the bioprosthetic valve to be 20-25 years?
That is the burning question right now, sir. Average lifespan is 12 years, 10 to 12 years. So we are, if the patient is 60 years, we are looking at 2 valves in his lifetime. If the patient's age is 50 years, we are looking at 3 valves in his lifetime. Previously they were saying that you put a mechanical valve in these patients, but mechanical valves are not without their own problems. We commonly see prosthetic valve thrombosis when patient has to take warfarin or acetylene. The dose adjustment is a problem. So with improving valves, now there is a new valve which has been launched called Resilia from the surgical side, and they claim that there is no structural degeneration up to 12 years, and they are anticipating up to 20 years. So even the surgical side, there has been a lot of progress in the valves. Also the newer surgical valves which are being made are designed in such a way that future TAVI inside a surgical valve will be more easy to perform. So the valves are being designed in such a way that we can perform a TAVI inside a surgical valve, and we have done 2 cases who had come with a degenerated aortic bioprosthesis, who were operated in 2010, 2011, and they came with a degenerated aortic valve. So the biggest question right now in this field is, should we do surgery TAVI if the patient needs 3 valves? Should we do surgery TAVI if he needs 2 valves, or should we do TAVI because even that is possible? But as far as possible to avoid a mechanical prosthesis in somebody who is above 55 years is, I would say, reasonable, because we now have surgical valves which can give you a fairly certain predictable outcome for 12 years, whereas the mechanical valve is an unpredictable outcome for 20 years. Like I said, you will live longer, but you need more procedures.
What about putting a valve in a valve? What are the gradient across the valve?
So we have to use preferably those valves which have a supraannular platform. I will come to that soon. So if the age is more than 65 years right now as per the guidelines, the life expectancy should be more than 1 year. If you are doing a TAVI in somebody who has a grade 4 malignancy which is inoperable, then that doesn't make sense. The surgical risk we have still limited ourselves in the initial few cases to high and intermediate surgical risk. Now slowly we are progressing to low surgical risk. What are the contraindications for TAVR? First and most obvious is patients needing mechanical prosthesis. Centers which have no cardiac surgery backup on the side, because if there is any complication in a TAVR, your only bailout is the surgeon. Estimated life expectancy less than 1 year, and patients who have mobile thrombi in the ascending aorta or the arch of aorta. TAVR is usually performed through the femoral axis, but we can perform it through alternative axis like carotid, subclavian or transapical, but that should be limited to centers of excellence in experienced hands, and they are still class 2B indication to do TAVR with non-transfemoral axis. And active endocarditis is the obvious contraindication because the infection has to come out before we can do the TAVR. So this was a very nice article which was published in European Heart Journal in March by Samir Kapadia and group. And because there is so much excitement about TAVR, they wrote an article about not everybody who should go for TAVR and who should go for surgery. And I think it was a wonderful article because surgery still is a very important place in the treatment of aortic stenosis. So the younger you are, right now the consensus is to go for surgery. Although there is now a debate that if you are younger, then you put a TAVR and then in the second surgery, the surgeon removes the TAVR valve and then does a SAVR, and then your third procedure can be a TAVR inside a SAVR. But surgeons still don't have enough experience in explanting TAVR valves, and the mortality right now is very high, up to 30%. Dr. Vinayak Bapat in Chicago is the leading expert, and he's propagating this theory that in your 50s you get a TAVR, in your 60s you explant the TAVR and do a surgery, and then in your 80s you again go for a TAVR. So you at no point will you have more than 2 valves in your body. If the surgical risk is low or if the patient is not frail, then we should go for SAVR. But if the surgical risk is high or prohibitive and if the patient is frail, then we should go for TAVR. CT scan plays a very important role in decision making, and in Kikabai now we have made a rule that every aortic stenosis who comes to me at least has to undergo a CT scan before deciding the therapy. And because of that, in the last 5 years, in the last 1 year, the number of Bentall surgery has increased from about 1 or 2 to 7. And that is because we found after doing CT scan that the aortic root dilatation was very common. We found healed type A dissections in 2 patients. So I think surgeons also can do a much better job in the surgery. They can implant bigger size valve. They can choose their patient beforehand with regards to which patient should go for a root enlargement by doing a CT scan before proceeding for the surgery. So I think CT scan is very important. If they have concomitant other valve disease like mitral regurgitation or tricuspid regurgitation, then it prefers to go for surgery. And if they have critical 3-vessel disease, then again we should prefer a surgery. But if they have 1 or 2 vessel disease, then we have done one case where we did a rotablation to the LAD, put a stent and then did a TAVR in a 79-year-old. Very important is patients who have aortic root disease, and as we are doing more and more CT scans, we are finding more and more root disease which were previously getting missed. And patients who have active endocarditis, these patients should definitely go for surgery. They should not be offered TAVR unless they have prohibitive surgical risk. So like I said, the cornerstone of this therapy is in the CT scan, and we are analyzing now our CT scans ourselves. We have purchased the software and we are not relying on either the company or the radiologist to analyze the CT, because 60% of the procedure is in the outside the lab. What you are doing inside the lab is just implementing what you have planned in the procedure, in the CT. So when we do a TAVR CT, we have to analyze certain parameters, starting with the heart and going right up to the groin. because we will be advancing the valve from the femoral arteries. So it is a step-by-step assessment. The first and most important thing which we need to measure are certain dimensions, like we need to measure the aortic annulus. When we used to do a 2D echocardiography, we always, when patient used to go for surgery, we would measure in the parasternal long axis view the aortic annulus in the short axis, and that would give the surgeon some idea of what size valve he has to put. But when you can see the annulus in 3 dimensions, then you can get a perfect assessment of the annular dimensions, and the sizing of the valve will depend on the annulus measurements. Also, we need to measure the sinus of Valsalva, we need to measure the ascending aorta and the LVOT, because the TAVR valve has a significantly bigger frame as compared to the surgical valve. Another very important thing which we always assess is the distribution of calcium on the leaflets, because sometimes if there is a very heavily calcified raphe or if the valve is bicuspid, in that case TAVR may not be the best option. Also, we measure the height of the coronary arteries, because when we do a TAVR, we are essentially opening the native leaflets into the aorta. Now, if we are implanting a valve and the native leaflets get pushed up, and if the coronary is very low, then we may obstruct that. So one of the life-threatening complications of a TAVR procedure is obstruction of the coronary artery during the procedure. So this is a very important assessment with regards to the height of the coronaries, because if the height of the coronary is low, then we have to take certain preventive steps like prophylactically stent the left main or do a leaflet laceration, which makes the procedure more complex. Also, the TAVR, the next part of the assessment which comes is to decide the deployment angle. Whenever the surgeon is visualizing the aorta on the table, all the 3 cusps of the aortic valve, which is the right, the non and the left, they are in a straight line. So when he implants the valve, he will make sure that the depth of the valve is equal on all sides. The valve is not canted in one particular direction. So we need to find a fluoroscopic view in which the nadir of all the 3 cusps should be in a straight line, because we are visualizing a 3-dimensional structure in 2 dimensions. So it may so happen that if we are not in the right view, then we may misanalyze the depth on one side and the valve will be very low or very high, and that may lead to paravalvular regurgitation or conduction disturbances. So the CT will help us to decide the optimal fluoroscopic angulation of the C-arm while doing the procedure. And the last thing which we analyze is the entire route from both the femorals up to the heart, wherein we look at the dimension of the femoral arteries, the iliac arteries, the descending aorta, the aortic arch, the branching pattern of the aortic arch, the amount of calcification, and the dimensions. If your femoral arteries are less than 5 millimeters in size, then we may have to turn down the patient for TAVR, because the current delivery system is 14 to 18 French depending on the valve, which needs at least a femoral artery size of 5 millimeters. So if the femoral arteries are very small, then we cannot do a TAVR from the femoral axis. In that case, surgery may be a better choice. Coronary angiography before doing TAVR. So all surgical aortic valve replacement will always get an angiography. In TAVR, cardiologists are a bit lazy. They have not clarified the guidelines till now. What we are following in Kikabai is we are still conservative, because we have lost one patient who had a sudden death after doing a TAVR after going home, and we believe that it was coronary occlusion, and he may have had a lesion. And so what we are following is we assess the CT. If the calcium score in the coronary is very low, and if we have no artifacts in the coronary arteries, and if the proximal segments of the arteries are clean, then we just take one shoot of the left and the right at the time of the procedure. But if there is any calcium in the coronary arteries, or if there is a suspicion of coronary artery disease, patient is post bypass, or on the CT you suspect that there is some lesion, then we do a coronary angiography few days before the time. Angioplasty is recommended for any epicardial stenosis of more than 70% in the proximal segment of the vessels. So if there is a proximal RCA lesion or a proximal LAD lesion, then we have to stent that. The timing is again controversial. In Kikabai we generally try to do it on the same day as the TAVR because it reduces the cost of the treatment. But if it is a very complex angioplasty, then we may have to address it before the TAVR and then give an interval of 4 weeks and then do it. So coming to the valves, there are two technology of TAVR valve which are available.
Before you speak about the valve, once you have done an angioplasty and then you do a tower, this strut should not attach the coronary arteries.
So sir, if I can, the root is going to be pretty wide, the sinus of Valsalva. The coronaries will arise from the sinus of Valsalva. The valve, generally the distance of the valve will be dependent on the valve orifice. So if it's a 23 annulus, the valve will be of a 23 millimeter diameter. In that case, you will have enough room on the sides to access the coronary. One of the problems of TAVR is that if the sinuses are very narrow, then you can get an occlusion. And secondly, in future, if the patient has normal coronaries but he develops an MI, then re-engaging the coronary in some of the valves is a challenge. Yes, so it can be a challenge to re-engage the coronary, especially in the Medtronic valve. But in a short frame valve, like the Merrill or Edwards, or in a large cell valve like Boston or Abbott, you can go through the valve and engage the coronaries. Also, there are a lot of newer techniques which is called the commissural alignment, in which you align the, so when a surgeon does the surgery, he will always align the commissure of the surgical valve with the commissure of the native valve. So, but in TAVI it is not predictable because you are just going in and you are implanting the valve and the valve is crimped. So there are now techniques which are developed where you align the commissures with the native commissure, so you get more easy access to the coronary in the future. But this can be one of the challenges, and that is why in a young patient who has got a coronary artery disease, you should consider surgery if possible, because that can be a challenge. Or you choose a valve which will not hamper your coronary access. So if your coronary is 18 millimeters above the annulus, the valve frame is only 16 millimeters, it will not reach up to the coronary. So there are two technologies. One is a balloon expandable or the short frame valve, and the second is the self-expanding or the long frame valve. The two companies which are manufacturing the balloon expandable valve is the Merrill MyValve and the Edwards Sapien valve. And three companies are currently manufacturing the self-expanding valve, which is the Medtronic Evolute, the Abbott Portico, and Boston, which is just launched, which is the Accurate Neo 2. Now, briefly to discuss the differences between the two valves. The balloon expandable valve is crimped on a balloon like a stent. You cross the valve, you inflate the balloon, and the valve expands. It's a very simple technology. It will always be circular. It will take the minimal diameter of the valve, of the annulus, and it will have good radial strength because you are inflating with a balloon. The other advantage is it's a short frame valve. But the aortic annulus is not always circular. When the patient goes for surgery, the surgeon excises calcium and makes it circular so that a circular valve fits into an elliptical annulus. Here we are putting a circular design into an elliptical structure. So there are two drawbacks. One, balloon expandable valve in small sizes tend to have higher gradients, and higher gradients means less longevity of the valve. And second, that this valve is an annular platform. So like sir was saying, if your surgeon has put a 19 valve and inside that I put a 16 or 18 Tavi valve, then it's going to cause a patient prosthesis mismatch, and the patient will have a gradient of 30 after the Tavi. So in a valve in valve, this is not a good choice. As compared to that, the self-expanding valve is made up of a nitinol frame, You go in and you release the valve, and the valve expands as nitinol regains the temperature of the body. And in this, if you can see this diagram, the valve is higher. The leaflets are sutured somewhere here. So your native valve will be here. So it is a supraannular platform, which means that even if you don't have a circular orifice at the aortic annulus, you will always have a circular orifice at the leaflet level of the new valve. And hence this valve will give you better hemodynamics. This comes at a cost of, because it's a taller frame, you will have trouble in accessing the coronaries.
But does a self-expanding valve have as much radial strength as a balloon expander?
No, but you can always go in and post-dilate a self-expanding valve. So you implant the valve, then you take a balloon and you inflate it.
That is the expansion complete on table or it takes some time for the.
It usually expands within the first 10 to 12 minutes, sir. But they say, the company says that up to 24 hours expansion can happen. But all the experts say that what result you get on the table is what stays. So
You do the balloon expansion on table or you do it?
I will show you a case. So you do it on table.
Do it on table.
You assess the hemodynamics, and if the gradients are high or if you feel the frame is under expanded, you do the balloon dilatation on it. So choosing the valve is very important, and that is why CT is important, because the decision of which valve to implant depends on the CT. If you have large orifice, more circular annulus, balloon expandable valve, short coronaries, balloon expandable valve is a better choice. But if you have small annulus, which is common in our country, which you have degenerated bioprosthesis, in that situation, a self-expanding valve is a better choice. So these are two fairly different technologies. It's not like choosing between two stent of two different companies which are almost the same. These are two different technologies with completely different mode of mechanism of working, and hence the decision of which valve you choose is very important. So coming to the procedure, so the patient gets admitted one day before the procedure. The procedure is done under conscious sedation. There is no general anesthesia. Patient is completely conscious during the procedure. We insert a central line and a Foley's catheter one day before. We take two accesses, a right femoral artery and a right femoral vein, and a secondary access in the left femoral artery. A temporary pacemaker is inserted for rapid pacing during valve deployment, so that the cardiac output can be stabilized and the valve doesn't move with the contraction. We perform what is called as a pre-close of the puncture site, because we are going to advance really large bore devices through the femoral artery, and once we remove them, there will be a lot of bleeding. So what we do is we deploy these suture based devices which are called as a ProGlide, which is a suture based knot which can be deployed in the femoral artery, and when you come out with the sheath, you just tighten the knot so that the seal closes. On an average, the patient stays at home in the hospital for 3 days. He is mobilized on the same day and he stays in the ICU for 1 day. So that is a huge difference as compared to surgery. So I'll just show you one case, and this is a case which we did in a 79-year-old man, and this is what we start with. We have a pigtail from the left side, we have a temporary pacemaker in the right ventricle, and we have a central line in the right atrium. So this is the initial setup of the patient. If you can appreciate, this is the aortic annulus. This is the angioplasty which had already been performed for this patient in the LAD, and these are his left coronary and right coronary arteries. The first step what we do is, we take any coronary catheter, usually a left Amplatz 1 or a right Amplatz 2 depending on the root size, and we cross the aortic valve, which actually in the initial days was a routine, so you people are much better than us because you had to do every angio and hemodynamics in almost every case. which we are not being trained as new residents. So we cross the aortic valve and we advance this catheter into the left ventricle. We then exchange this catheter for a pigtail catheter and we perform hemodynamic measurements by measuring the transvalvular gradients, the LV end-diastolic pressure, so that we know if there is any regurgitation after the procedure, the LVEDP will go high. And we also measure the pulse pressure in the aorta at the time of the procedure. We then, in selected cases, perform a balloon valvuloplasty. This also I think was routine for all of you, wherein we take the balloon which has been sized to the minimum diameter of the annulus and inflate it so that it facilitates valve tracking and easy delivery of the valve across the annulus, because sometimes in a very calcified, sir, this is another case, so it's not one case. So this patient had a mitral prosthesis, which is a Hall valve, which was done in 2006 and now developed aortic stenosis. So you can see this jalebi wire. This is a safari wire which is developed by Boston Scientific, and this wire is generally the workhorse wires in the LV. We rapid pace at 180 beats per minute so that the cardiac output drops and the balloon doesn't move. After this, once we have done the balloon dilatation, we have an 18 French sheath in the right femoral artery and we advance the Tavi valve. So this is a Merrill-May valve, which you can see the 3 dots are the balloon and the valve has been crimped on top of the balloon. And we advance this valve from the groin through the sheath up the descending aorta, across the aortic arch and into the ascending aorta. This has to be done very carefully because atheroma can get embolized into the cerebral circulation. The next thing what we do is, because the aortic valve cannot be visualized on fluoroscopy unless there is heavy calcification, we had a pigtail from the left side that is kept in the lowermost point of the non-coronary cusp and we take an injection. Now if you can appreciate, this valve has certain dark bands and certain light bands. So we have to position the valve in such a way that the light band is at the lowermost part of the cusp, and that will give us an adequate depth of deployment. We are doing all this usually under pacing so that the cardiac output is low. We want the blood pressure to be not more than 90 systolic, because with every contraction otherwise the valve will jump up and down. And once we are comfortable with the position of the valve, then we go ahead and inflate the balloon, and this again is done under rapid pacing, and then the valve gets deployed. So this is the balloon which is getting inflated. So it's a wonderfully simple technology. It's like doing an angioplasty, but only you are shooting with a cannon and not a gun. And once that is done, we do a transthoracic echocardiography to look for the gradients, to look for paravalvular regurgitation from the sides of the valve, and we perform a hemodynamic assessment to look for any AR, and we do a final aortogram to see that the coronaries are flowing and then there is no leakage across the valve.
Two things. I can see some staining on the LPO.
So that this one?
Yeah.
So that is in the diaphragm.
It's in the diaphragm.
Yeah. It is, even we were wondering what it is, but it is some, probably she had a old tubercle which has left a calcific thing on that.
What is the residual gradient after you have looked at that?
Usually it is in single digits. In a balloon expandable valve, if you have adequately sized it, it will be between 8 and 10. In a self-expanding valve, it will be 3 to 5. It is much lesser than surgery, because you are always putting bigger valves. If you see in India, most of the time surgeons will put 19. If they are having a good day or in a good mood, 21. Right? But we will usually put the smallest valve I will put is 23. I will never put anything less than 23. If the valve size is coming less than 23, I will put a self-expanding valve. Because invariably you will leave gradients of 15, 16, on the table, and the higher the gradients, we know that the valve degenerates faster. So that's where again the valve choice is important, that if the annulus is very small, and choose a self-expanding valve, because you can put a bigger size valve in the same anatomy. The entire procedure, if done smoothly, doesn't take more than 25 minutes. We then remove the sheaths in both the groins. We close the right-sided sheath. If there is any conduction disturbance, then we keep the pacemaker for 24 hours. If there is no disturbance, we remove the pacemaker. Patient goes to ICU for 1 day, and next day she goes to the room, and third day she is discharged. So this is about the procedure in general. It is not free of complications. There are 5 major complications of Tavi. Stroke, which is obvious because you are manipulating in the aorta and when you inflate the valve. The risk of stroke is only about 2%. They have now started developing these cerebral protection devices, but the logic is that the stroke rate is so low that it doesn't make so much sense to deploy it right now, so all trials are negative. Second is bleeding, because you are using a very large bore access. They are old patients, they are frail patients. This is the biggest concern right now, is the groin. Third is conduction disturbance, because the valve, which happens even in surgery, because the conduction system closes very close to the non-coronary cusp. So while you are inflating the valve, you may impinge on the conduction system and patient may require pacemaker. This rate is also not very high. It was about 12-15% initially, but with improvement in technology and operator, it has come to about 5%. Kidney injury because of contrast, and paravalvular leak, which is leak which happens from the side, because the surgeon will very meticulously take suture at every point. So paravalvular leak is very rare, but can happen in heavily calcified valves. So that is one of the concerns